Hello, and thanks for listening to the MiCare Champion Cast. With the general election right around the corner, today's episode will focus on why getting to the polls November 5th is so critical to the future of healthcare in Michigan. We'll talk about what issues are top of mind in the healthcare policy space, what the MHA's role is when it comes to healthcare advocacy, and how to engage and support our state's healthcare champions. Joining me in studio, I have Laura Oppel, a returning guest who is also our Executive Vice President of Government Relations and Public Policy at the MHA. Since joining the MHA in 2000, Laura has focused on strategic priorities related to state and federal lobbying and healthcare policy analysis. She was recognized in 2020 as one of Crain's notable women in health and is really one of the most qualified people to talk with us about the election, given her long history in policy, lobbying, and leadership. Laura, welcome back.
Well, thanks so much for having me.
I actually want to rewind back to my first week at the MHA because a woman named Laura Hall, who had this position before me and actually used to host this podcast.
Oh, yeah.
I think I've told you this before.
I don't know.
She onboarded me and gave me a piece of paper that outlined everyone's role at the MHA. And next to you, she put, Laura's going to be your encyclopedia of all things health policy. So I feel like I want to start by saying that because it really showcases your expertise in this area and why we asked you to be our guest for this topic.
Probably related to my longevity.
Yes, absolutely. And your longstanding history in this space. So if you don't mind, I know you've been a guest of the podcast before, but can you start just by reminding our audiences about your role at the MHA?
Sure. So I'm an executive vice president here at the Michigan Health and Hospital Association, and the areas that I'm responsible for are 4 divisions. Finance, which helps members understand what's going on in Medicare, Medicaid, and commercial payers like Blue Cross Blue Shield or Health Alliance Plan, things like that. I'm responsible for our communications division, which you are a great part of, and then our policy division, which is kind of a research arm and a place where we develop ideas and carry out ideas. And then that group is very engaged with our advocacy division, where our lobbyists work and help get policies that we need implemented, whether they're through regulatory action or legislation at the state or federal level, or prevent things from happening that we know would be injurious to hospitals.
Right. And before we get into the conversation about the election, I think it would be good if you don't mind sharing some of the issues that are top of mind for you and the team right now.
Absolutely. I'm going to start with workforce because workforce is absolutely the priority of the MHA because we know it's something that is super important to our members. If you don't have the staff, you can't deliver the care that people need.
Right.
And I know that I've probably said this in previous podcasts with State Representative Julie Rogers, to recognize all of the people that work inside a hospital that make it so that people are well taken care of. And by that, I mean not just the nurses that you see, but the patient care techs, the people who draw blood, the people who deliver your food, the people who transport you from your room to getting an image taken and back again, the people who make sure that your room is clean.
Yeah.
And I am missing, probably 2 or 3 dozen other job classifications, but we need all of those folks, and we're slightly short. And in some cases, really short on all of those jobs, and so we've had the support of the legislature in making significant investments in recruitment and retention. I'm really excited that we have the ongoing support of state government. Something I want to mention specifically is Michigan Reconnect, and I know we can link to that in the show notes. Michigan Reconnect for people currently who are 21 and older and don't have a certificate or a degree can use state resources to get community college without paying tuition.
Yep.
And some folks might say, well, that's all well and good, but I don't have time to get a 2-year degree. I can't go to school full time. There are careers like becoming a pharmacy technician. We very much need pharmacy technicians. I'm just talking about hospitals. I think there are other places, whether it's commercial pharmacies, retail pharmacies, or FQHCs, federally qualified health centers, nursing homes, other places where they could really use those services to get a certificate as a pharmacy tech takes about 16 weeks. And I was just with a pharmacist yesterday who works in a large hospital up north, and he said that the starting wage for somebody who's a pharmacy tech is between $16 and $18 an hour. So invest 16 weeks in getting that training, and you can come out of it making over $30,000 a year if you can find the right role for you. And again, Michigan Reconnect will help you figure out how to do that with full tuition assistance. So we partner with state government. I also want to make it clear, we are partnering with community colleges. We're partnering with four-year universities. We're in development of, we always need to do more work with Michigan Works, but it was a partnership between Michigan Works and the hospital in Ludington to get started on what's called a nursing apprenticeship. And in that case, people start being in the hospital in a paid position, but clearly not a nursing position, as soon as they start nursing school.
Right.
And it's a way for them to learn about the hospital and what goes on there and what it's going to mean to be a nurse. But, as they are training to be a nurse, as they're doing that education. And I think it's just a terrific model. And I really I know many of our organizations are looking at how they could match that.
Yeah, and partner with educational institutions.
Right. And we were talking earlier as we were getting started, if you are looking for chances to get into a healthcare career, look up your local hospital. There's a great article that just posted on LinkedIn. You can read about a remarkable program between Northern Michigan University and Helen Newberry-Joy, small hospital in the small town of Newberry, Michigan, in the Upper Peninsula. Helen Newberry-Joy is offering help with scholarship as well as being a training site for people that are going to be clinical lab professionals. And, I think it's already generating, people who are newly prepared for the workforce for Helen Newberry-Joy. It's another example of people are not standing still to figure out how to fill these positions that we need.
And we also have our myhospitalcareers.com webpage, which I know we plug a lot on the podcast, but I think it's just, to your point earlier, there's opportunities there that are clinical and non-clinical, and we need people in all of the teams of the hospital.
Yeah, and I think that hospitals are a fantastic place to think of the career ladder. You could start in pharmacy tech or clinical lab or patient care tech. And after a few years, you might say to yourself, I really like this work. I'm going to start working towards a nursing degree. I promise you, if you are working in a hospital, the folks there are going to support you in that.
Right.
And let's say you become a nurse and you think, I love this work. And as a nurse practitioner, I could see patients individually, in a clinic setting and help them preserve their health and, take care of them in advance. I promise you, the hospital is going to support you in that.
Right.
And so there's just, there are many stepping stones to advancing your career in hospital work. And our favorite example
is Bob Briney.
CEO Bob Briney, who started, sitting at the desk in the nursing student dormitory and is now, having that remarkable experience at Henry Ford, where they did the groundbreaking on a, gigantic project.
My friend just graduated from her CRNA program, and she's starting at Henry Ford. And I actually told her yesterday about Bob Briney. I was like, did you know his history at Henry Ford? And she's like, that's amazing.
Yeah. It's a great example.
Yeah, absolutely.
But I want to say about staffing that, we just mentioned that we've made some strides and we've got some great programs going and we've got some good partnerships. In 2023, we did a survey of our membership, and we found that we were short 27,000 people specific to hospitals, not including those other places that you might work in healthcare that I mentioned earlier. And we had more than 8,400 openings for nurses. In 2024, we repeated that survey, and we have fewer than 5,000 openings for nurses. So I'm convinced that our hospitals are doing everything that they can think of to get and keep nurses. And this leads me to the conversation you were saying, like what's going on in the healthcare policy space. There was a lot of attention in the first half of this legislative session to nurse staffing ratios, government-mandated staffing ratios, saying in every hospital, in every circumstance, regardless of the patient acuity, regardless of, rural or urban, regardless of tertiary care center or critical access hospital, these are the rules on how many people have to be on the floor, depending on how many patients you have. And the analysis is that from the side pushing House Bills 4550 to 4552 or Senate Bills 334 through 336, the analysis for those supporting those bills is only by imposing government-mandated staffing ratios will we bring nurses to the bedside. And I think that we, knowing that we have reduced our shortage by more than 3,000 nurses in 1 year is solid evidence that it's not staffing ratios that are going to bring nurses back to the bedside. What I see that people are doing is chief nursing officers are investing in their nurses. Mm-hmm. They're learning about what the stressors are. They're learning about how difficult it is for new nurses to adjust to the hospital setting. They're setting up ways for them to be successful. Salaries for nurses have increased, mm-hmm. and most places are increasing them on an annual basis for the next few years. I can't talk to those organizations that don't have people who are represented by a union, but in the cases where people are part of organized labor, it's public information. There have been news stories published that pretty much the contracts that were settled in the last 18 months provided for 3 years of raises in a row, well-deserved, certainly well-earned. I think that represents some forward momentum there as
Absolutely,
well. So there's things that are going on. We certainly, still having more than 4,500 nurses short, and we know that this is not going to get a whole lot better in terms of we have an aging nurse workforce and they are retiring.
Right.
Nursing is a difficult role. Nursing, you use your body all day long because you're on your feet, and you use your brain all day long because you're thinking about who the people you're taking care of and what they need and the drugs that you have to pass and all of those things. So certainly understandable why people want to retire, but I think we are well down the road of understanding and doing the work we need to get and keep nurses in our hospitals.
Right. I think we needed some time after the pandemic to find our footing and figure out how things have changed culturally speaking. And I think even, a couple episodes back, we talked to Munson about their 24-hour nurse line. I think that's so innovative and such a strong example of how the industry is changing. It's not an easy job, but it's different than traditional nursing. And it just offers a new opportunity to be in the field and explore that in a different way.
Yeah, and just going back to the staffing ratio issue, government-mandated staffing ratios, the one-size-fits-all approach can put hospitals in an untenable position. Mm-hmm. You either pay large financial penalties because you literally cannot get the nurses that you need, or you have to close units. You might have been in a hospital and you'd see there's a hallway that's dark. That's what we refer to as closing beds. Mm-hmm. There's 12 beds in that hallway. We can't use them because we don't have enough staff. That happened post-pandemic because there weren't enough nurses. Units had to close. We think it's pretty self-evident that passing government-mandated nurse staffing ratios will make that more frequent, not less.
Right. Yeah, I appreciate you bringing that up. What else is top of mind? I know 340B. We can't forget
340B. So I know that probably most people who are listening to our MHA podcast have a lot of expertise in healthcare. But on the off chance that someone is listening that is new to all of this, I just want to make it clear that why is something called 340B and what is this jargon that we're using?
I think that's a good place to start.
So a lot of things in the federal nomenclature are named after the section of a law that they end up in federal statutes. And in this case, that section is 340B.
Right.
So it's just the shorthand for the place where this program is created and defined.
Right.
And now, okay, what is this program?
Right. And I think its longhand name is the 340B drug pricing program, right? Okay.
340B drug pricing program.
I got that right.
And what it does is the federal government, the Congress, and obviously signed by the president at the time, which is many, many years ago, they said, here's a way that we can help hospitals who need help. We're going to say to pharmaceutical companies for a certain set of hospitals, and I'll talk a little bit about those next. You must sell drugs to those hospitals for their outpatient services at a very significant discount and give them a break. And the type of hospitals I'm talking about are hospitals that are what we call DSH or disproportionate share hospitals. Those hospitals take care of a lot of people who use Medicare and Medicaid for their services, or could be uninsured or underinsured, people with high deductible plans, which is very prevalent now. And our smallest rural hospitals, like critical access hospitals that have only 15 beds, have high fixed costs because they have so little volume to spread the cost of their ED or their pharmacy costs, et cetera. And the thing that I also want to point out about this is the requirement here is for the pharmaceutical companies to sell drugs at a lower price to these hospitals who don't have a lot of financial security. Doesn't even show up on the federal budget.
Right.
Because the federal government doesn't do anything here. They said to the pharmaceutical companies, you have to offer this discount. You have to provide this discount. So it's not costing taxpayers to do this. It's an agreement that ended up happening again many years ago. But unfortunately, in this program, the pharmaceutical manufacturers and others are thinking, we're not excited about how frequently we're being asked to sell these drugs at this discount. We don't like that there are other places that patients are picking up their drugs other than inside the actual hospital outpatient department. That ignores, they say, well, you're letting people pick up these drugs at their local pharmacy. I think all of us have left an outpatient procedure and almost directly proceeded to our local pharmacy to pick up the prescription.
Right.
And that is a very efficient way of doing it. Until Rite Aid closed, you might have had a good relationship with your local pharmacist, like I did. And now we're making new friends at other pharmacies. But the idea that somehow it's a bad situation because people are going to pick up their drugs at a place other than right inside this outpatient service provider, which, again, sometimes you do that.
Right.
But, there's efficiencies in not having pharmaceuticals available every 15 feet. All prescription drugs have to be cared for very carefully.
Yeah.
I say this all the time to folks. There's a reason things that we see are quite inexpensive to purchase over the counter look expensive in the hospital. And that's because they move from the pharmacy to the place where they're going to be dispensed in the hospital inpatient or outpatient setting. They're kept in what's usually a pretty big machine that's locked up. All of the little boxes of that machine, it has to be we have to know that what's in the box that says aspirin is aspirin, and what's in the box that says acetaminophen is acetaminophen, because people have allergies.
Right.
So those things have to be, we have to make sure the right thing is in the right place. The machine that they're in is expensive. You have to have a person who's qualified to fill the machine.
Right.
And all of those things, the chain of control of pharmaceuticals is critical to making sure that patients are safe.
Yeah.
And pharmacies, retail pharmacies, which are contracted with these 340B hospitals to provide this to patients, they're doing all of that.
Right.
And to duplicate that inside of a tiny hospital, inside of a tiny critical access hospital, when there are other places that are already doing all of that, we don't need to duplicate that service. The other thing that happens is places like the University of Michigan, Henry Ford Health, Helen DeVos Children's Hospital on the west side of the state, they attract patients from all over the country because of the special services that they can do, because of the highly qualified clinical professionals that they have. And then those folks are going to go back to Wisconsin, Pennsylvania, Colorado, wherever, and those patients might need to continue taking drugs on an outpatient basis, and they can be very expensive drugs, drugs for cancer, oral chemo, things like that. So you might say to yourself, well, why do you need to contract with a pharmacy in Colorado? Because that's where my patient is.
Yeah.
And I'm extremely proud of the fact that Michigan is a destination for high quality care.
Yeah.
And we should be. And what a fantastic thing that we have such great people doing such impressive work. But that's why, healthcare doesn't stop at our border. And I'm sure that there are very fine institutions in any state that you go to, but we're right up there with places like the Cleveland Clinic and Mayo Clinic and other places in like New York State or whatever. And we're attracting patients from other states, and that's why this program works the way that it does.
Right.
So we're working to protect that. We're working on a bill, House Bill 5350. It protects the opportunity to have contract pharmacies wherever a 340B hospital needs that to be to serve the patients that they have. We are excited about the amount of support we see in the state legislature now. Our advocacy team has worked immensely hard on this, and it really almost nonstop on 340B for a couple years now to help people in the legislature understand the program and why this legislation makes sense. When we contract 340B, what happens is the savings that those hospitals get by paying a discounted price for drugs, they are able to use those savings. For example, one of our hospitals says, well, we know there are a lot of people who can't afford the part that they pay for their chemotherapy. We can use those savings to support our infusion drugs that those patients need and keep them cost-free or nearly cost-free for those patients.
Right.
And when we contract 340B and say you don't get as many savings or you can't, do this in as many different ways as you've been doing it, it contracts a program like that. It makes it more difficult to serve everybody who needs to be served. Other folks would argue, well, you're getting this discount, you should pass it along to each consumer individually. I am so lucky. I'm pretty sure you feel the same way. We are, the MHA is a great place to work.
Yeah.
And we have good salaries and good benefits. I don't need that benefit passed along to me. My employer does very well by us in terms of our health benefit plan. It makes a lot more sense to bundle those savings and get that support to the people who need it. And if you gave it individually to me, it would be a nice little discount, but it's in no way meaningful to the person who can escape a high deductible of $5,000 or $10,000 that they have to apply towards their chemotherapy, and we can just get them started on that without that stress. I think having cancer is stressful enough.
Right. Right. Yeah. And I'm not as close to the policy side of 340B, but I have had the pleasure of speaking with our members about it and getting some testimony from Memorial Owasso recently. And also we've heard from Trinity and Mackinac Straits, and the stories they tell of how they're benefiting from the 340B program is outstanding. And I think to your point, I actually want to quote you from your last podcast episode talking about the 2022 election, but you said, "We know how proud of ourselves we can be based on how we treat those who need the most care." And I think that concept really applies to the 340B program.
Absolutely.
And one of the other things and big focuses that I know we're going to keep, honing in on in the new program year is cybercrime. So we spoke with Jack Kufal a few months ago at U of M earlier about why it's important that hospitals aren't held liable for acts of cyber criminals. But what can you tell us about any legislation that's in motion in that space?
So I want to take a step back and do a quick, very high-level definition of why we're using the term cybercrime. Mm-hmm. A lot of folks talk about cybersecurity, and it's important that in a place like a hospital that has a lot of information, a lot of personal information about people, information that they don't want anyone else to see, can be valuable to criminals. We need to do everything we can to make that secure.
Right.
And I was talking to someone not long ago about Corewell, or we were talking about cybersecurity, and they said, well, Corewell basically has, I'm probably exaggerating, a football field-sized unit where everybody's working on cybersecurity. Mm-hmm. And I just give that as an example of how seriously everyone is taking protecting that patient information. Protecting patient information is, everyone understands how critical that is.
Right, and just to point out, that's obviously a member who is a bigger sized hospital, and they have a lot of resources. So we have to also consider the members that don't have the ability to fund a football sized team, of cybersecurity experts. So
at the same time that everyone is doing their best to protect patient information and all information, there are people overseas. Their full-time job is to try and figure out how to penetrate health systems and get that information and hold it hostage.
Right.
And that's a crime. Absolutely a crime. I really appreciate that the legislature and our attorney general are seeing those crimes for what they are. When someone does a successful criminal attack on a hospital and finds their data and holds it hostage, it is not for lack of trying on the part of the hospital to keep that information safe. Imagine your own home and you had, you're doing a really good job. You lock your doors. You might even have an alarm system or whatever. But there's someone all day long looking around thinking, how could I get in that house? Mm-hmm. How might I get in that house? And you're not thinking about that full time. Hospitals do have people thinking about full time, but there's just somebody on the other side of that working the whole time. That's their job, is to just figure out how to commit this crime.
Right.
So we do have legislation now pending in the state legislature, and the Attorney General asked the legislature to introduce these bills, Senate Bills 888 through 892. We haven't heard a lot back from the membership yet about how they're looking at these, but we see it, for example, very positive that the HIPAA exemptions for notice are maintained. So we don't have to tell people things that would violate HIPAA. That's important. And we appreciate that recognition that state regulation and federal regulation need to match, so that we're not duplicating the effort and we're not setting up one to conflict with the other.
Right.
So we are, we've been trying to work very closely with the Attorney General's office. They've been very responsive to help them with, help us be resilient to these crimes. And we actually have in the MHA's 24-25 action plan a lot of effort aimed at that, helping our hospitals develop that resiliency. And you'll probably be hearing more about that, and that might even be a subject for later. But that's where we are, and that's probably the first and earliest thing on cybercrime that I can mention right now. And there's going to be a lot more to come on that topic.
Yeah, and just to go back to your analogy with the house break-in, it's like if somebody broke into your house and then the cops came and arrested you.
Yeah, exactly.
Oh, that's a good way to think of it.
Burglar's really good.
Right.
So,
we're going to arrest you or hand you a big old fee just for,
Yeah.
Well, I appreciate you sharing some of the things that are top of mind right now for you and the team. But I do also, I know this is an election episode, I promise we're going to get to it, but I think it's important that our listeners understand exactly what the MHA's role is in terms of healthcare legislation. So can you provide maybe just a recent example of how we've successfully advocated for Michigan hospitals?
Absolutely. Something that has become much worse, deeply troubling, is the amount of violence healthcare workers are experiencing. And for anybody who's listening to this, who works inside a hospital, volunteers inside a hospital, please know that everybody here at the MHA is so frustrated that that this is happening, and there are some really very difficult stories, and we take this extremely seriously. We are always thinking about what we can do on this topic. One thing that we were successful in doing last year is we got some legislation done on healthcare worker safety, bipartisan package. It was 4520 and 4521. Those are now Public Acts 271 and 272. The governor signed those at Sparrow Hospital. It was a terrific gathering of all types of healthcare workers. Everybody was up on that stage, and there were some difficult stories told about the threats that were made to people, completely unprovoked. I mean, I'm not saying that if you provoke something, you deserve violence. I'm just saying, like, people walked in with this violent approach,
right?
And there wasn't even a conversation that preceded it. So, that legislation doubles the financial fines for people who are found guilty of assaulting either a healthcare worker or a volunteer. And that was a joint effort with our hospital, other, people who lobbied directly for a health system. They were part of that. The Nurses Association is part of that. We're grateful to the bill sponsors and to the governor for signing it. I'm grateful to the governor for signing it at Sparrow Hospital so we could show people how important this is. And, TV showed up, print journalism showed up, and we really got that story out. But I think that's a great example of, something that was really needed. Didn't go as far as we wanted. Way more work to do on this one too. But we got started down the path of getting people to understand how much worse it's become, and at any level, it's unacceptable. I think people would be shocked. I don't don't generally think people think it is acceptable. I think they would be shocked at
how
the
bad
rate
it really
and
is.
how bad and how people are treated. And so, again, I'm really proud of our advocacy team for the work that they did on that. It was a tough one because people are really reluctant to increase penalties for crimes right now. I think there's kind of the pendulum has kind of swung. Like, we really went long way to like really punishing people, and maybe not as effective as they thought, and so kind of like not interested in doing more of that. But we succeeded in doing that just the same.
Absolutely, yeah. And I know that especially leading up to the general election, some of the topics that are related to healthcare are really polarizing. But I think healthcare violence, and there's a lot of others, but healthcare violence is something that's bipartisan. Both sides are absolutely trying to work against it. But to get into the election, I think this is probably a pretty simple question, but I do want to ask so that people understand, how does voting influence healthcare at a local level?
Sure. So we are very focused at the MHA on supporting what we call healthcare champions. And regardless of us who is in control, I worked in the legislature when it was all Republican control. We currently have, I was never there when we had all Democratic control, but that's what we have now. And in between, I was there for shared power in the House. We had, Republican Senate and House and Democratic governor. We've had every mix. There are always healthcare champions on both sides of the aisle.
Right.
There are always healthcare champions on both sides of the aisle. And we find those people and having them in the legislature and sometimes in local government. Oakland County Exec Dave Coulter is a great example. Huge advocate for mental health. He worked in that area before he was elected at the county level. Those are the people who carry our message. Those are the people who help us get money for rural labor and delivery services that are suffering. Those are the folks who help us get the Medicaid budget done every year. We need, regardless of who's in charge, we always need somebody from the other side of the aisle to help get what's called immediate effect and get that budget to take effect by October 1. Mm-hmm. You might not know who of your neighbors use Medicaid for their health care. Medicaid covers almost, it certainly covers 1 in 4 people in Michigan. So 25% of us need Medicaid to help them out. And it's really the insurance coverage for people at certain income levels and below. Getting that Medicaid budget done means that our neighbors have the coverage that they need. Mm-hmm. And certainly that makes a big deal to our hospitals because then they can get paid for the services that they're offering and delivering. But even more so, it means that people have coverage when something terrible happens to them. And in the years past, when we didn't have the expansion of Medicaid that we do now, there were certain people who were just never eligible, no matter how low your income, no matter how few resources you had. And people would have thousands or even $100,000 worth of medical bills. And as a staffer, I would work on these constituent problems, and they'd say, well, I need help with this. And because they were not a parent, because they weren't elderly, because they weren't disabled, a person didn't qualify for Medicaid. And there was literally nothing we could do. And the anguish of those people, I never want to repeat that. Mm-hmm. And so we what politics means is the people in office are making the decisions that make a big deal to people's health care on a daily basis. Mm-hmm. They make the decisions about that 340B program we just talked about. And our hospital is going to have that discounted pricing that gives them the savings that helps them help other, people in the community whose coverage doesn't quite get to where it needs to go, or other services that they can deliver in the community because they generate those savings. The people who are our champions help us make all of that get in place and stay in place, and in some cases expand if we can afford it and it makes sense.
Right. Yeah. And when it comes to the presidential race and the candidates that we have coming up, where would you say, we asked this question actually to Rick Pollack as well, Brian did in an episode recently, but where would you say healthcare ranks in the conversation under each administration?
Well, you've probably heard a lot of things about child care tax credits. You've heard a lot about tariffs or not tariffs, credits for small businesses. We're not, and we've heard about reproductive health. But with that exception, healthcare is really not part of the conversation right now. From a national perspective, but we have 2 of the most, what will likely be the most expensive congressional races in the country. Michigan's 7th congressional district, Michigan's 8th congressional district. There's going to be immense spending in both of those. And there are definitely there are definitely conversations that are happening at a much more personal level about, this, and you can see by people's records, where they stand on healthcare. So you're not probably going to see a major set of advertisements about protecting the Affordable Care Act.
Mm-hmm.
But I promise you that if your member of Congress comes to your door and you ask them about it, they're going to have an answer.
Right.
Yeah,
Absolutely.
They know about it and they're prepared for that, and they have an opinion on it, and then you can decide if that opinion matches up with your values and if they're a healthcare champion that way.
Absolutely. And can you tell us a little bit more about what you mentioned about the expensive races for the 7th and 8th districts?
So we've all seen the polling that Michigan has a very tight race for the president, which means it's a very tight race for our electoral college votes. We have perhaps maybe a little less, polling-wise, a little less tight race on our Senate race to replace Debbie Stabenow. But Alyssa Slotkin is running against Mike Rogers for that Senate seat. Representative or Congresswoman Slotkin has left her House seat to run. So that is considered kind of a 50-50 seat, 50% Republican base, 50% Democratic base. The control of the House is in the balance, the U.S. House, and that makes that seat very difficult to win for each side. So you're going to pour a lot of money into that. Michigan 8, Dan Kilde's retired. That seat is considered a 50-50 seat. And you're going to see a lot of money poured into that. Each one of these seats is could be one of the ways that defines who's in charge of the U.S. House of Representatives. And because we're close on the presidency, close in the Senate race, close on 2 congressional races, yes, you are seeing a lot of advertisement now, and expect it through the election day. You're going to see it on broadcast. You're going to see it on cable. You're going to see it
on our social channels.
Streaming. You're going to see it on social. It's going to be everywhere. But here's the thing. Michigan counts.
Right.
Michigan is important. Michigan has a very strong voice. It's tough to be in this environment, but there's a guy who has his own journalism outlet in Nevada, and he always kind of ends everything he writes with "We matter," meaning the state of Nevada matters. Mm-hmm. Michigan, we matter.
Absolutely.
And we have a lot more electoral votes than Nevada.
Yeah, absolutely. And I know we're not getting into, every race on the ballot this year, but I do just want to make a call out to the fact that we're going to have our Race of the Week articles on our newsroom starting in early October. So if you are interested in learning more about the candidates on the Michigan ballot specifically, definitely encourage our listeners to head there. We learned in the last episode that you were engaged in advocacy and voting from a very young age, but I am curious what your advice would be for someone who maybe wasn't raised in that environment. How do they get engaged or take an interest in voting?
So headlines are written to make you, it used to be to get you to buy the paper. Now it's to get you to click on the link, right?
Right.
And so, see if you can remove yourself from the hyper-partisan headlines. Look at things that are, or maybe, look at the stuff that's below the headline, or even go to people's websites. Their stuff is going to be laid out there. It might not be a thorough explanation of everything that they're talking about, but you will definitely get a sense of where people are. And you might see some stuff that really appeals to you there. What happens with, your role in this decision-making is just what I talked about in terms of, electing people who pay attention to healthcare, who care about healthcare, who care about hospitals, having the resources that are necessary to take care of folks. And you have the chance to decide to get those, you're deciding to get those people in office.
Right.
And it's absolutely critical that we have those people. And again, it's never been permanently about Democrats or Republicans in control. It's always been about those folks who understand the role of hospitals, understand the role of healthcare, understand that patients come first, and sometimes our really good friends, we don't agree on everything,
Right.
but. And so if you're looking at voting for somebody, you're like, well, I like their positions on this, but this I really can't take. Think about that. Think about like what are the highest priorities. I think you really will. If you're thinking about what does this mean to my job, what does this mean to my insurance coverage, what does this mean to whether or not our rural hospital can survive. Those are pretty big deals. I mean, it's a lot more than just the headlines about like what crazy things somebody said today and how you can spin it to make it look good or bad for the person, depending on what side you are on, for or against them.
Right.
And I'll be the first one to say that I see things and I have a gut reaction and I have to remind myself, just don't look, turn that off, move away. It's too stressful, and there's probably just a grain of truth to whatever it is you're looking at anyway.
Yeah, absolutely. And I think it's important that we encourage our clinicians and the people, even people in non-clinical roles in our hospitals, to get engaged and make their voices heard, because they're the experts when it comes to healthcare issues, big and small. They know what they're talking about, and lawmakers are looking for their input and their guidance. And I think that can't be emphasized enough. And speaking of our role in all of it, I think that we're a great resource for people that work in our hospitals, and people that don't. Patients can come to us and bring those issues to us, and we can make that connection to lawmakers, and we can say firsthand that our lawmakers want to hear from not only us, but their communities.
Pretty much anyone who's working inside a hospital and inside an outpatient department, it doesn't have to be in the four walls of the mothership, but whatever your role is, X-ray tech, you almost for sure, with few exceptions. I mean, once in a while we have a few doctors in the legislature, a few nurses. Right now we have a physical therapist. But with the exception of those few people, we have 110 members of the House. We have 38 members of the Senate. So we have 148 folks together. I don't think we've ever had 5 people at one time that I would call experienced in hospital life.
Right.
So you as an X-ray tech can probably give them greater expertise than just about anybody else they're going to talk to among their colleagues and among their staff. I mean, years ago, we had somebody who was a lawyer and a nurse. She reminded us of that regularly. But I'll give her credit. At least she's a nurse. I'm not.
Right.
That's the last time I know of a staffer that we had who had that clinical background. If you drop into your lawmaker's coffee hour or spend a few minutes with them on the porch, if they, drop by to say hi, introduce yourself and say, I work in a hospital. And you might have some questions sometime about what does something mean or how would it work or whatever. You send me a text. I'd be happy to, share what I know about it. And I promise you, you know more. You're and they will appreciate understanding from you. Almost always, the people that are voting on stuff want to be better informed, and they, having somebody that they could quickly reach out to. You don't have to be the CEO of the hospital, although they're fine too. But if you are part of hospital life, your expertise is valuable, and don't hesitate to share it.
Yeah, and I think people would be surprised too. Dr. Yarrow was on the podcast a couple months ago, and she said, when my staff brings me problems and solutions that I can then bring back to lawmakers, like that is helpful to hospital leadership. So I wouldn't even, write off your role if you feel comfortable approaching your leadership at your hospital. I think it's worth a shot, and you voice what's happening so that they can get it in front of the right people too. Yeah. But
I know everybody's got a full-time job. A lot of people have young people at home, or are taking care of others in, extended family or whatever. Maybe you're also trying to go to school. Maybe you work one shift and your spouse works the next, those kinds of things. So there's probably thinking there's not a lot of extra time to, throw at this. So maybe it's not your turn right now. It'll be your turn the next time.
Right.
But if you are one of those people who can take on that role, I can't tell you how much we'll appreciate it from our perspective here at the MHA to have your voice out there.
Absolutely. And I think we're all kind of accustomed to the texts kind of asking for donations from our lawmakers. And I'm not even talking locally. I'm just talking, we've all gotten the text. But I want to talk about a little bit how we can support healthcare champions in the legislative space during and beyond the election cycle and beyond the funding side of it. What else can we do? Can we show up at coffee hours? Can we engage with them in other ways? What would you recommend?
I think absolutely going to people's, in addition to having coffee hours, people have town halls. Mm-hmm. This is probably going to seem a little unusual, but lawmakers are always looking for ideas. And if you were to share with them something that you could have identified as a problem and said, I really wish we could change X. This is a regulation that hinders us from helping certain people in a certain way. This wasn't related to healthcare, but a prosecuting attorney in Saginaw wrote about something that made it difficult for him to take on people who were driving uninsured. I like, this is a pretty good idea. Asked somebody to introduce a bill, and it became a law. And so if you have good ideas that way, people are looking for what makes sense to do. Because we all have good ideas about other people's work or circumstances. And I think we all play really good tennis or football or whatever in our minds, right, even though we're not the professionals. But, our ideas about how to solve problems are not as well informed as the person who's experienced the problem. Mm-hmm. And so I think that that's a way that people really can help folks and give them their support, is to help them really understand what's going on, mm-hmm, and suggest to them, things that need to be fixed, because they don't want to do something that doesn't make sense either.
Right.
But there's a lot of people making policy that they haven't. I was a policy staffer for 14 years. I didn't do it directly about healthcare, but there was stuff I worked on that I didn't know anywhere near as enough as people that were working right in healthcare.
Right. Yeah. Laura, I thank you so much for being here. I'm so grateful that we had a chance to talk before November. And I asked you this last year, but I do want to ask again, what is motivating you to get to the polls this year?
So this year, I think that there are a number of things about Medicaid funding that are at risk. And so I'm definitely motivated by that. But, I think I've shared in the past, the way that I grew up, voting was just kind of part of what happened. You went to the grocery, you went to the gas station on election day, you went to the polls, kind of thing. It was just how it went. But so I tried to get like a little how did that carry on? Why today? Why now? And I think that what it really comes down to is this is your chance to influence the process and the outcome. We don't have a thing where all 335 million of us can vote on each thing as it comes along. So we got to send people. We send 435 of them to Washington. We send 148 to the State House. This is your chance to get somebody there that is the best representative out of the choices that you have. Nobody's going to be 100% of what you want. This is the person who's going to represent you in the process and the way it happens and what the final outcome is. And I want to emphasize the process. The way we get things done makes a huge difference in whether or not we can get them done. And we've got some really good people on the ballot this year who are part of, let's get this done. Let's work together. We can all pull together to keep things moving, keep things going in the generally right direction. So, the House Republicans are in charge of the House right now. The Senate Democrats are in charge of the Senate, U.S. Senate. Whatever they come up with, neither side is going to be entirely satisfied with it. But they have people there working that are interested enough that they're not going to insult each other. They're not going to draw hard lines in the sand. And days in advance of October 1, when this fiscal year starts again, we already have a budget deal that's going to go to the president to keep the federal government running.
Right.
The disruption of government shutdowns, even the uncertainty of whether or not there will be one, process matters. Look for people who are going to be a good addition to the process, and think about the outcomes that you want, because we're not going to vote 335 million people at a time. So this is our chance to send our person who's representing our slice of the 335.
Right.
And, we get it every other year. So, and every 4 years for president, this is your time. And it makes a huge difference in the way that things work in terms of hospital finance, in terms of decisions about patient care.
Access.
It's always on the access to care. It might not be the thing you're voting on the ballot, but that's what underpinning, why to get there and get your vote in. Also, Michigan has early voting now.
Yep.
You can vote by absentee ballot right now, and you can go do that in person at your clerk's office, and then actual early voting, where you can go do like what you would do on election day and stand at the little cube and fill in your blanks. That, I believe, starts October 26th.
Perfect. That's coming right up.
That's coming right up. And but you can vote right now, and you don't even have to. You can request an absentee ballot in person, fill it out while you're standing there, and hand it back to them.
Right.
And don't hesitate to do that.
Yeah. You can't use the excuse that it's too hard, because they've made it extremely easy to vote. So thank you so much, Laura. I appreciate your time and expertise. And your vote, you'll see it all over our channels, but your vote makes a difference to Michigan's healthcare future. So
Absolutely.
Thank you so much for being here.
Lucy.
With that, I'd like to thank our listeners for tuning in. For more information on the upcoming election, you can head to our elections page at mha.org or visit michigan.gov/elections. As always, all details from our conversation and the resources mentioned will be included in the description of the episode.